Hi, good morning. My name is Ciro. I'm the resident from University of Campinas, and I will make the presentation today. The case is about a penetrating trauma in thorax. The patient he was a male, 20 years, and received and have three lesions by a knife. Okay. Well, the history the patient was taken by their friends to the medical service and was referred to the trauma center. The history, the patient received 3 stabs, one to the left chest side. This was the pre-hospital evaluation. The patient probably was drunk, was hemodynamically stable, and received in the pre-hospital 1 liter of lactate ringer. And the time until the trauma center was 2 hours.
About the pre-hospital, the patient visited a facility that you have in Brazil for emergency, uses for clinics emergency. You call pronto atendimento in Brazil, and the patient received the first care in this unit. And after this, they called the ambulance to transfer to our hospital, the university hospital. So the first discussion is about the delay to the patients arriving in the trauma center, the trauma hospital. It's about 2 hours. And the patient received 1 liter of crystalloid. So we want to start the discussion about these topics in pre-hospital. I know in United States, in other countries, totally different. But what you suggest when the patient go straight to a very simple facility with few resources. Usually you have only an emergency physician doctor, or sometimes a pediatrician. You don't have surgeon at this place, but it's a place where the patients usually go because it's close to their home. And this patient went direct from the scene of the trauma to this facility. So Gary, please start the discussion.
Dr. Fraga, I have a question. We have a question first. So this 2 hours delay was because the patient stayed in this facility for 2 hours for initial management, or because this facility was far away, was 2 hours drive by an ambulance to your hospital?
The delay is because you called the ambulance. Was 5 a.m. in the morning on Friday, and to transfer the patient to our hospital. Usually to go by car from the hospital to this facility is about 20 minutes.
Okay, so he was not like a faraway area that was 2 hours drive. So it was just the logistics of preparing the transportation. Okay, it was not something that you would need a helicopter, for example, to make a 2 hour drive and 20 minutes drive. It was just a delay on the how to get an ambulance to transfer to your trauma center, correct?
Correct.
Okay, thank you.
Sao Paulo, Dr. Calais?
I can talk. It's very common in our country. The patients will go to a small hospital and need to go to a trauma center or maybe a hospital, university hospital. There is a delay because the ambulances on the sites, ambulances is rented. So the small hospital need to call the ambulance. The ambulance that delay around 20 to 2 hours or 3 hours or 4 hours to take the patients to the other hospital. Usually, the patients must be stable, and during the stay in the small hospital, the patients continue to be reanimated. So sometimes it's difficult because the logistics of our country, but the problem is all the people working in the small hospital must be training to adequate resuscitation of the patient. Here you can see the stable on the patient is a penetration injury. If you get too much volume for these patients, maybe this patient may become more unstable quickly than if you do more no too much volume for this patient. So it's very important to know this. So the people working in the small hospital need to know the difficulty of the transportation, and they can continue the resuscitation during they stay in the hospital and during the transportation. That's unfortunately is our problem, but it is working, and some people it saves more life than if you don't have any other.
Thank you, Dr. Calais. Dr. Severa, would you like to comment?
Yes, in Thailand, our pre-hospital service, usually they cannot find the IV line and give a lot of fluid. They just pick the patient up in the spinal board and transfer quickly to the nearby hospital. We have a pre-hospital system and level of trauma centers in Bangkok and in other provinces too. But usually what I experienced, the pre-hospital service will just take the patient to the nearest hospital first. And after that, if the patient is too severely injured, the patient will be initially resuscitated and then transferred to the bigger hospital too. For this case, stab wound to the chest, and he was in shock. The best thing for him is to transfer him quickly to the center that can operate on the patient, and not giving a lot of fluid is a wise decision. But because you need time to transfer the patient to definitive care, you have to give him some fluid to maintain vital signs. So hypotensive resuscitation may not be practical in a country that cannot transfer the patient very quickly to the OR. Because if you make him too hypotensive for a long time, the patient may undergo cardiac arrest before being operated on. Thank you.
Thank you, Dr. Supa. Qatar, Dr. Hakim, your comments, please.
Yeah, Gary. Actually, it all depends on the place where this incident occurs. Depends on the system which is in place in that area. If it would have been in Qatar, probably in 20 minutes, this patient would have been in the trauma center. But again, if you talk about any other place where the resources are limited, the systems are not in place, probably this is how it goes. It might take a couple of hours, maybe more, and maybe just angiocath in place, maybe 500 ml of fluid going in, and the patient is transferred. I mean, not as an emergency. I mean, that's because there's lack of a system in place. So if it happens like this in the place where the incident has occurred, though this is inadequate, but probably we have to accept the fact. Thank you.
Thank you, Dr. Hakim. Dr. Severa. Lei Severa, would you like to comment? Okay, anyone else like to comment before we return to Campinas?
Yeah,
Okay,
just a comment, Gary.
Okay.
Just a comment.
Yes, sir.
So this is this happen a lot, not only in Brazil, but in many countries, even here. I received a patient the other day coming from the Keys, a gunshot wound. Was a helicopter transfer. The patient was hypotensive during the whole flight, not receiving blood. And as you know, when you have a prolonged hypotension, you can have other problems. So this patient, we survived, did the surgery, but then the patient has some other problems with prolonged hypotension, some limb ischemia, or a patient that had another patient that some years ago that the patient had the optic nerve necrosis, ischemia due to prolonged hypotension. So this is a big issue when you need to transfer a patient and have delayed transfer the patient hypotension for a long time. In the United States, we have two systems. Every patient that goes to a hospital, walking in the hospital has the ability in the first 30 minutes to call a trauma alert. So even if the patient goes there, he can call EMS as a trauma alert, and the EMS come and quickly transfer the patient to another hospital, to the trauma center. Because just an inter-hospital transfer, like in other countries in the world, takes a lot of time. So if in more than 30 minutes, needs to be a transfer, you need to call the transfer center to another hospital. You have a physician to accept the patient, then this can take hours. So that's why here, even if somebody goes to a trauma center to a small hospital. It's a trauma. The small hospital can do a trauma alert, and then the trauma ambulance, the trauma crew comes and transfer the patient to the trauma center. But again, delays happen everywhere, and this can make the prognosis of the patients not good. Thank you.
Thank you, Dr. Marttos. Back to you, Dr. Fraga.
Okay, let's continue. When he comes, the only alteration in the exam was in B. The sound was reduced to the left side, and he has a peripheral saturation normal was stable. The Glasgow was 14. He was drunk. Yeah. And at the E, what they call we see different is the 3 perforation in the chest without R or blonde. Let me put the image. This is the vital signs. I'm sorry.
So the patient was totally stable. He received 1 liter of crystalloid, and I think you can see one stab wound here, anterior axillary line, the other next to xiphoid appendix, and the other in the thoraco-abdominal transition on the left. 1, 2, 3 stab wounds. And the patient
Fraga,
was...
Did they do any X-ray in the UPA? Any X-ray? Anything else in the during 2 hours waiting to transfer to your hospital? Or
No X-ray in the another facility. He came direct. He was stable, so he had three injuries in the chest, very small, less than 1 centimeter each one, and the sound was decreased, a little decrease in the left. A little decrease the sound in the left. You can see the vital signs. The patient was totally stable. Do you want to discuss now, Antonio? You can discuss, are there X-ray or E-fast? What they use in each hospital?
Operation room.
Let's start with Qatar. Dr. Hakim, your comment, sir?
Yeah, if this patient has reached the trauma center, is stable, but at least we need to start with an ultrasound, E-fast. We need to evaluate the chest, we need to evaluate the cardiac area, and do an X-ray quickly. Thank you.
Thank you, Dr. Hakim. Bangkok, Dr. Supul, your input, please.
I agree with a fast exam to check the abdomen and to check the heart for any cardiac tamponade, and to get the chest X-ray. And we go from the result of the investigation. Thank you.
Thank you, Dr. Supul. Sao Paulo, Dr. Calais, your comment, sir.
I agree with the comments. If you can make an X-ray in the emergency room, you can make an ultrasound, maybe because a face, maybe pericardial window to see if there is a tamponade. But in this situation, the patient is stable. 1 hour that you have, I believe that's more specific than go to angio CT in this situation, because you can see all the things that you can find. The patient is stable, can see the abdomen if there are fluid, there is injuries. If you can see the pericardium in the angio CT, you can see if fluid in the pericardium. More than you can see the fast exam. You can see if patient is stable, can see if a small pneumothorax or contusions of the chest. So in this situation, the patient is very stable. I prefer to go to this patient at this moment to angio CT.
Thank you, Dr. Calais. Any other comments before we return to Dr. Fraga and Campinas?
Yes, Gary. I think these injuries are very tricky, because we have 1 injury in the box, right? So it's very concerned for cardiac injury. The other one, the axilla, you can have some vessels there, but the other one, the left side, the thoraco-abdominal region, that's another tricky one also. I agree. I would start with X-ray, can fast be done here, yes, but the patient again is already 2 hours out. So if he also had a cardiac injury bleeding to the chest, for at some way is contained or stopped. But even if after CAT scan, if the CAT scan is negative, so what we do, since he had this left thoracoabdominal penetrating injury, you would keep the patient admitted for 24 hours and to be sure that there's no peritonitis, and then we'll do a laparoscopy just to check for diaphragmatic injury. Not to check the bowel. Wait 24 hours, clinical examination. If there's no peritonitis, I will just go to check the diaphragm after 24 hours with laparoscopy. But let's see, for sure that's this patient is not stable. There's something else happening here. Let's see what Dr. Fraga and his residents are going to tell us. Dr. Fraga, I'm looking forward for the problems on this case. Thank you, sir.
Thank you, Dr. Marttos.
Okay, so the idea of the team at the emergency department was investigate the cardiac injury by the FAST or EFAST and the thoracoabdominal injury with suspicion of the diaphragm injury. The patient was stable. The patient will be sent to the CT, but before the CT, you have the chest X-ray.
Yes, we can see a blonde in the left side. And then we make a AFFILIATIon. Let me show the AFFILIATIon.
So the chest ray was hemothorax on the left. You can see hemothorax on the left. No pneumothorax. The quality of the photos not so good, but no pneumothorax, only hemothorax. And the EFAST.
The only altered part of this exam was the left chest, where we can see fluid.
So the hemothorax with blood on the left. The question now is, put a chest drain or go direct to the CT. The pericardial window by the ultrasound was negative. Gary?
Yes, sir. Bangkok, Dr. Super, your comments, please.
For stab wound of the chest, I usually don't use a CT scan of the chest routinely, unless I am worried about great vessel injury. Because for cardiac injury, we can rule out by performing a fast exam or even echocardiography by radiologist. And for the bleeding in the chest, we could use either EFAST or chest X-ray to check for bleeding. Unless I suspect bleeding from great intestinal vessel, I would not send the patient to the CT scan. In this case, if fast exam is negative for pericardial fluid, and we see left hemothorax from the fast and chest X-ray, I would put the left chest tube in and observe the bleeding from the left chest tube. And finally, in this case, like Dr. Marttos mentioned, he has left thoracoabdominal stab wound, and we should be concerned about possibility of diaphragmatic injury. So later, maybe few hours, if he remains stable, no peritoneal sign, I think we should take him for the laparoscopy to rule out the diaphragmatic injury. Thank you very much.
Thank you, Dr. Super. And Sao Paulo, Dr. Calais, your comments, please.
Yes, you have small pneumothorax because the patient is not become unstable. So there's no pericardial blood in the pericardium in the FS. You have a thoracoabdominal injuries, can see. Patients don't have fair that is no size of peritonitis. So I believe these patients need to go, I prefer these patients to go to an angio CT, see the size of the hemothorax and see if there is some evidences or some signs of peritoneal injuries. If not, I can go to the put the patients to a OR and make a thoracoscopy and see the diaphragm evacuation the blood of the left chest. The patient is stable. There is no reason to put a chest tube in the emergency room. You can put in the OR and you can make more exams and can see what is happening with the patient. And then you can make to investigation of the diaphragm. You can use drainage of the hemothorax, evacuation, the hemothorax, and see the diaphragm. That's the way I go.
Thank you, Dr. Calais.
Gary?
Doctor, well, one more,
Gary?
please. Qatar, doctor again.
Yes, I would be a bit more careful regarding the wound in the center, though the ultrasound may not have showed any pericardial collection, but there is a chance if the pericardium is open, any blood which would have normally collected in the pericardial cavity can still be leaking, maybe towards the left chest. So I'd still keep that option at the back of my mind that he still might have a pericardial or a cardiac injury. Second, I would look at the labs just to see if he has bled little or has he bled too much in the left pleural cavity, because the ultrasound shows only a very small amount of fluid. I'm not very sure about the quality of that ultrasound. So a base deficit and a lactate would definitely tell me that is the bleeding into the left hemithorax quite significant or is it quite mild, which would probably decide whether I put in a chest tube now or should I wait till the CT is done. Thank you.
Thank you, Dr. Hakim. Any further comments before we return to Dr. Fraga?
Yes, Gary, this kind of injury is very tricky, you know, because I saw injuries before that the penetrating injury perforated the heart. Since the pericardium was open, drained to the chest. For sure, this patient, if he had this kind of injury, for some reason, this stopped for a while, but this can start bleeding again. And some small, we saw some small cardiac injury that still by itself is really small, but he may have like a small injury to the heart or to the pericardium, and pericardium is open, and then he bled a little bit to the chest. I'm concerned about the patient. He's not out of the woods yet. So I agree, Dr. Collet, he's stable right now. Some people would say, let's go to the operating room, do pericardial windows first, and then place a chest tube. But some people say, oh, he's stable enough for more than 2 hours, he can go to the CT scan. So it's a tough situation. So again, he's stable now, but you should not neglect that he has an injury to the Ziegler zone, to the box. So need to be really concerned about some cardiac injury that's just stopped bleeding right now and was bleeding through the chest, through the pericardium that was open. Let's see what happened.
Thank you, sir. Dr. Fraga?
Good discussion, because I think it's a consensus to investigate with a CT, and I think it's consensus that this patient probably will need a surgery to investigate the diaphragmatic injury. So let's go what Dr. Ciro did.
What we make the chest drainage was indication, and the patient being stable was being stable was referred to tomography.
300 milliliters of blood, 300 milliliters. Now, Dr. Lais, she's a resident in radiology.
Hi, good morning. My name is Lais, and I'm 30-year resident of radiology here in Campinas. And I will present the images of this case. Can you see?
Yes, very
Yes.
good. Thank you.
Yes.
Here are the CT of the abdominal and pelvis, and we can see at the abdomen that there isn't any free fluid, and there are homogeneous enhancement of the spleen. So the abdomen is okay. There isn't any alteration of the thoracic image. We can see there is a pneumothorax and a hemothorax, pulmonary opacities, and subcutaneous emphysema. Can be for the penetration trauma or for the drainage procedure. Here.
So there was a pulmonary contusion, hemothorax, no signs of COVID-19, the alteration that you usually have in CT, because you are always looking for this nowadays. And there was another information, which is the other information, Lais, about the pericardium.
Here we can see this anterior mediastinal hematoma. There is adjacent to the pericardium, and we can see no hemopericardium. So just this hematoma, there extra pericardium here. The picture, it's easier to see. Here, this hematoma, the hemothorax, and no hemopericardium.
So the ultrasound at the emergency department was correct, no hemopericardium, but was a hematoma. It's very difficult to definition if the hematoma was in the chest wall or at the pericardium. Probably at the pericardium. What to do now? Gary, please moderate the discussion.
Yes, sir. Dr. Hakeem, your comments, please.
So I didn't understand the radiologist's comment regarding the pericardium. Is it injured? Did she find a track which goes into the pericardium, or the pericardium is intact?
It's a question for you, Dr. Fraga and Campinas.
Sorry, please, can you repeat the question, please?
Yes, the radiologist said that there is something in the pericardium. I'm not sure. Is the pericardium intact, or there's a penetration which is going through the pericardium? Because she must have seen the images very clearly.
Yes, it's very difficult to have this answer by the CT.
No, I mean, what did she comment? I was not very sure about her comments.
I think she said that there's no fluid inside the pericardium.
No fluid.
But she saw hematoma on top of the pericardium, right?
Okay, so around the pericardium there is still a hematoma. I mean, okay, thank you.
Correct, but no fluid inside. So, but I think she cannot exclude like pericardial injury. Correct, Fraga? Okay. Dr. Fraga?
Yes, probably there was a pericardial injury with hematoma, but no free fluid, no blood in the pericardium.
All right.
Just at that point, there was this blood, this hematoma. Lais, can you put the image again? Because it was a long discussion with the radiologist to understand, is this hematoma in the pericardium or the hematoma in the chest wall, in the pleura, parietal pleura, and was difficult to have a definition. But at the same time, you need to perform investigate by the diaphragm. Yes. So I think it's important to discuss, because I think Dr. Supa told about investigate by video laparoscopy and Dr. Collet by thoracoscopy. which access you should start if the patient go to the OR. Or you can just observe the patient and don't send the patient to the OR. I think this is the point of the discussion now.
Okay, does that satisfy your question, Dr. Hakim?
Yeah, it's okay.
Okay.
Thank you.
Thank you, sir. Let's go to Sao Paulo, Dr. Calais.
In this moment, the comments that I have, I agree that the patients need to see if there's a diaphragm injury and can see the pericardial injuries. You can go to a thoracoscopy. You can see the pericardium, can see if there is blood in the pericardial sac. You can evacuation the residue of the hemothorax and clean the pleural cavity, and you can see the diaphragm during the thoracoscopy. If you have injuries in the diaphragm, you can go to a laparoscopy and then see if there is injuries in the abdomen. You can observe the patient. It's clear that the patient is stable. There is no signs of hemopericardium. You can observe the patients. But sometimes if you have injuries in the thoracoabdominal transition, you go to see the diaphragm. So you can go to a laparoscopy later if you can decide for observation the patient and the fluid of the drainage of the chest. But I believe these patients can more safety can go to a thoracoscopy and see the pericardium and see the diaphragm. If there is no injuries, you can look at the chest drain and go and wait. The patients go quickly. Can use minimal invasive treatment. You cannot go to a surgery like a thoracotomy or a laparotomy in this situation.
Thank you, Dr. Calais. And let's go to Bangkok. Dr. Supa, your comment, please.
This patient may have cardiac injury because with hemothorax on the left side, the patient have a cardiac injury and bleeding, and the blood decompresses to left hemithorax. So we could not totally rule out cardiac injury by performing a fast exam on this patient. Anyway, now he's hemodynamically stable, and if the chest tube output does not increase and he's breathing okay, his vital signs remain stable, I would observe the patient, and maybe I would repeat echocardiography of the heart, maybe in 1 or 2 days, and see how the heart is. And once I'm sure that there is no further bleeding, no new cardiac tamponade, I would address the diaphragm later. Maybe I would perform a laparoscopy few days later after I observe the patient for a few days, and I'm sure that there is no active bleeding or no new cardiac tamponade going on. Thank you very much.
Thank you, Dr. Supa. Dr. Marttos, would you like to comment, sir?
Yes, Gary, this injury is tricky, because like Dr. Collet said, you can do a thoracoscopy and try to see the injury. So if you see the penetrate the pericardium, so what? Would leave it alone? Should you explore? If you're gonna explore, what should you do? Do a thoracotomy? Do a sternoctomy? I'll say in this area, what probably I will do here, and I had a couple cases like this. We did a pericardial endo. Okay, they do a pericardial endo. There's a little bit of blood. Now what? Should we explore or should we wait? So some patient like this will just do a pericardial endo, irrigate. Then if nothing comes, leave a drain and just observe the patient. If there's still some bleeding coming, they need to explore. I had 3 patients that I remember that developed cardiac tamponade days after the injury. One was 7 days, another one was 8 days. This about after trauma, this happened a lot. One was blunt trauma, another one was penetrating trauma. He had like small injury to the muscle and then bled afterwards. So this is a tricky situation. I think I would be I would sleep well if I would check what's happening to this inside the pericardium. You know, I'm not happy. And again, we know that small injuries can just seal. And I have remember some case from the military hospital Bogota, Colombia, years ago. Dr. William Sanchez showed that they found a small injury. They put some fibrin glue there and never did anything else. I remember another case that had a small injury, bled a little bit, and nothing needed to be done. The seal itself, but I'm still concerned about this patient. I would take a look of, I would do at least a pericardial window and see if there's no more bleeding coming from there. Maybe it's just, maybe what's happening is just this, there's a bleeding and this small hematoma is containing everything, is very fragile, and then this can rupture anytime. And I'm kind of concerned here to this patient. He's not out of the woods.
Antonio, do you prefer start with the subxiphoid pericardial window or by thoracoscopy or by laparoscopy? What is your first option to investigate this patient?
So laparoscopy you do only if the CT scan is clear, but you know you cannot exclude like bowel injury. Is not CT scan not sensitive for bowel injury for penetrating trauma like stab wounds. So our protocol here, if you have a thoracoabdominal injury, you know sometimes the CAT scan is not good. CT scan not good for diaphragmatic injuries neither. So you wait 24 hours. If the patient has no peritonitis, then you go do a laparoscopy just to check the diaphragm. It's not to run the bowel, etc. Should go just to check for diaphragmatic injury. If you have a suspicion of a cardiac injury, we do a pericardial subxiphoid pericardial window. If there's blood, it continues to have blood, then you do a sternotomy. So again, you know, in Brazil, we don't do a lot of sternotomies, and in Brazil, I only did thoracotomies, but here I learned to do sternotomies for cardiac injuries is the best approach. You can see the whole heart. But I would say probably here I would start as a pericardial window, subxiphoid. And again, that's the point. If I see some blood, some people say the board answer is just need to do a sternotomy to explore and see what's happening. Some people feel that, and I had patients maybe just pericardial bled a little bit and had fluid in the pericardial space. But I would start with a pericardial window, subxiphoid, and then if needed, I would do a sternotomy.
Excellent. And if you start with the pericardial window and you have a small amount of blood coming from the pericardium, so you go direct to a sternotomy, or do you wash the pericardium with physiological solution before opening the chest?
So we had a lot of discussion last month about, we had 2 cases exactly like this in a row here in Miami. Again, I would say if I open, there's a little bit of blood and not a lot of fresh blood coming, we can irrigate with fresh solution and see if continue to bleed or not, but leave a drain. But you need to be in a trauma center, you need to have experience to put the patient ICU, you need to be confident. The discussion here when I teach our residents and fellows, say, listen, the board answers, the answers that are in the books, okay? If you see a pericardial window that's positive, you need to explore, okay? So a lot of places, if you see blood, you explore, it's correct. If you don't explore, you need to know that you're deviating the protocol. We've done this here. We've done this successfully. A couple of times, like Dr. Ginsburg published some data about this some years ago. But you need to know that if this goes wrong, you're going to justify in a morbidity or mortality meeting, you know. I had a patient 2 months ago. Dr. Gabriel Ruiz had a patient also, and he presented a few weeks ago. For me, it was a blunt trauma with positive FAST around the heart. I did a pericardial window. And there's some blood coming, then clear, and then put the drain and stay watching 30 minutes. No blood was coming, and the patient did perfectly well. So again, if you deviate the protocol, we need to be in a good place. And need to have experience, and need to follow your patient. So I would say the right question is pericardial window. If there's blood, open, explore. but if you don't do that, you can deviate the protocol if you are experienced and you are in a place that can monitor this patient.
Excellent. I just asked you because there's a good paper from Heider Trauma Center, I think Dr. Ginsburg, with 3 cases when they did not open the chest. They just irrigate, and we know that our friends from Colombia, they have a large experience in cardiac injury. Dr. Collet, what do you suggest in this situation? If your resident suggests you start by pericardial window and a few amount of blood coming from the pericardium, do you prefer to irrigate or open the chest?
Gustavo, it depends. Depends where I am. If I was in the Hospital das Clínicas, if there is very small amount of the fluid, of the blood of the pericardium, I can try to make an irrigation and put a drain. But if I was in the hospital of the municipal hospital, that or the hospital that I work, I make a thoracotomy and see what's happened, because there is no horizontal evaluation of the patient. So it's very dangerous to take the patient with not a safe treatment. So safe diagnosis, safe treatment. So you can, when you put wash, you cannot see what's happened. You can suppose that there is a small injury. These injuries may become detamponate, and maybe sometimes the patients go there. So if you go to make this procedure, you be clear that you have some people go to review the patients every moment during the first 2 or 3 days to take this drain out. So don't do unsafe procedure if you don't have equipment or persons that can check the patients already. Some hospitals here in Brazil, you don't have it. So you can wait. And in the hospital's clinics, you can go and see it and can try to these procedures. But usually I go to, if there is blood in the pericardium, I go to make a thoracotomy.
Thank you, Dr. Collet. Dr. Supa, do you want to comment about this question?
If the patient has obvious signs of cardiac injury, like a tamponade, and he remains hemodynamically stable, I agree with Dr. Marttos to perform median sternotomy, because it was an incision of choice to expose all the heart. And if the patient is in extremis, if the patient has cardiac arrest or something, I would go with a left anterolateral thoracotomy for resuscitative thoracotomy. And for pericardial window, we usually perform this procedure when we suspect a cardiac injury, but no obvious sign from physical examination or from ultrasound, like in this case. If we are not sure about cardiac injury, we may perform pericardial window. And if the window is positive, we usually go on with a median sternotomy to explore the heart thoroughly and to exclude the cardiac injury. But from the evidence published from Ryder Trauma Center, they did median sternotomy in the patient with positive cardiac, with a positive pericardial window, and they found like 38% negative median sternotomy. So maybe mandatory median sternotomy after a positive window is not always necessary, especially if there is no active bleeding. But in this particular case, he does not have pericardial fluid and no active bleeding from the left chest tube. I'm afraid that if we go on with pericardial window, you may have some positive result, and then you may have to perform unnecessary median sternotomy, and you will find no obvious injury that need repair in this case. So I think about observing this patient and repeat echocardiography. And that's my thought on this. Thank you very much.
Excellent, Dr. Sup. Thank you. Do you think video thoracoscopy is a good option in this situation?
We are not familiar with thoracoscopy for diagnosis. We reserve thoracoscopy in trauma for VAT and evacuation of the retained hemothorax. But in this case, if you perform thoracoscopy, we may have to put the patient in right lateral decubitus. And if you see pericardial tear, it would be difficult to repair the heart on this position, because posterolateral thoracotomy is not a good incision to check or to repair the cardiac wound. And like I mentioned before, maybe if you find a pericardial tear and you open the pericardium up, you may encounter negative pericardotomy. Maybe there is no significant injury that needs to be repaired. Since the patient is quite stable right now, I try to avoid invasive procedures at this point. But he may need it later if clinically he changes. Thank you very much.
Thank you, Dr. Supa. Our friend from Doha, Qatar.
Yeah, thank you, Doctor.
Comment?
Yeah, so since the patient is stable, I mean, that decides how we manage this patient the coming days. I would definitely want to rule out a diaphragmatic injury. And if the diaphragm may be intact, probably the injury might be a bit lower than that area. Maybe he's taken an inspiratory breath, and I mean, during expiration, the stab has gone below the diaphragm. So I would definitely want to do a laparoscopy examination of his belly, rule out a diaphragmatic injury. And with regard to his pericardium, which is still a doubt, I mean, we are not sure whether there is an injury to the pericardium or the heart or not. So we can follow two pathways. Either we do sequential ultrasounds by, I mean, people who can do it, I mean, who are trustworthy in doing that, to see whether there is any collection which is increasing or increasing the cardiac tempo. Or we can do a pericardial window and check for the amount of blood which comes out. If it is considerable and it's active, fresh, then we might do a thoracotomy or a sternotomy, depends on the skills of the surgeon. But if not, I mean, then again you can follow it up, because the patient is stable, so probably that gives us options. Thank you.
Okay, thank you. Gary, can you send the image to us again? So the patient went to the OR. The idea was start with thoracoscopy on the left. And how about the intubation? Do you think it's mandatory to have a selective intubation or not? You use the endotracheal block that you can close the bronchus on the left side. What is the option in your hospital? Let's start with Doha, Qatar, for thoracoscopy on the left at emergence.
Yeah, you can definitely do a endobronchial intubation if you want to have a better view for that. The option is yours.
Okay, Dr. Collet.
I prefer to use a selective intubation in this situation, is it possible? If not possible, can go to, maybe stop the ventilation during the surgery, during the thoracoscopy to see the injuries. Sometimes I use, in other hospital that I don't have a selective tube, I stop the ventilation during some minutes, controlled by oximetry, and then the patient can see the chest, and then go to sometimes 3 times that I make this, and can see all the pericardium, can see the diaphragm, can see the lung, can see the other structures in the mediastinum by the left thoracoscopy. Prefer to use selective. The position of the patient, I usually, to make the thoracoscopy, I don't put in the lateral decubus. I put the dorsal and put a cushion or to make facilitation to see axillary space, then where I can go to manipulation during the surgery.
Okay, Dr. Supa. Thank you, Cole. Dr. Supa.
We need to collapse the left lung to perform effective thoracoscopy. And we usually ask the anesthesiologist to do that, and they usually use a double lumen endotracheal tube. So you can choose to ventilate the left chest when you need to. Because if you want to see air leaking from the left lung, you may have to ventilate the left lung sometimes. But initially, we would collapse the left lung and check the heart, the bleeding first. So that's the way we do it. Thank you.
Thank you. Antonio Marttos.
Go ahead, Dr. Marttos. Let's see, Dr. Marttos.
Yeah, I think he had to step away for a second.
Okay, let's go with the case. Dr. Ciro.
So, during the thoracoscopy, we saw blonde and pericardial hematoma, where we can see here.
So the anesthetist did selective intubation, and you can see there was a moderate to large hematoma in the pericardium. But the window that you can see, the hurt, no blood through free blood in the pericardium, only at this place. So we irrigate with physiologic solution to remove the clot, and the clot was very adhesive to the pericardium. So was a suspicion of perforation in the pericardium, but you did not find the perforation in the pericardium, only the hematoma. So it was time to call our friend from cardiac surgery. And I remembered Dr. Antonio Marttos, because by the iPhone, you showed him the image, and he watched the image from his home, and he told it was not necessary investigate and open the pericardium, because the hematoma was outside the pericardium, only at the pericardium, without perforation. So you just put the chest drain in the chest, and he just recommended us to have a ultrasound in the postoperative 2 days later, because the patient probably will stay in the hospital because of the chest tube, and you did not open the pericardium. So 2 days later, the patient did the ultrasound, and the chest tube was removed after 4 days after the surgery, and the patient was discharged at 4 days. This was the case. Was a lot of discussion in our hospital about the approach to this patient, and the patient recovered very, very well. Final comments. Gary, please moderate the final comments.
Yes, sir. Let's go to Sao Paulo. Dr. Calais, your final comments, please.
Yes, I have congratulations for the presentation to share the experience of the Unicamp for us. Thank you for the presentation.
Thank you, Dr. Calais. Dr. Hakim, your final comments, sir.
Yeah, thank you. Thanks for making it multidisciplinary also, bringing in the radiologist, and definitely a success, and the cardiothoracic surgeon surely. And thank you for making a successful management for this patient. Good job.
Thank you, Dr. Hakim. Dr. Supa, Bangkok, your final comments, please.
Thank you very much, Dr. Fraga, for your excellent presentation. I learned a lot this Friday. No, this is Monday, I'm sorry. And now I know that thoracoscopy can be used for diagnosing questionable cardiac lesion. And that's very educational.